All right, this is the lightning topic for the Journal Club series. We're going to start with guidelines presented by Julie Kapp. So when you're ready, Julie, take it away.
Thank you. So my name is Julie Kapp. I am getting my master's in nursing at Rush University, and I'm about to graduate this August. Okay. So first, I'll just talk a little bit about the methods for developing the guidelines. So it was an update from the version from 2012, and this version was published in 2014. And a panel of experts from the WMS based on research and clinical expertise gathered together. And they replicated the PubMed database search, looking for articles from 2011 to 2014, using the same keywords that were used in the 2012 guidelines. So those keywords were lightning, lightning strike, lightning injury, Lichtenberg, and then coronal paralysis. And there was also an incorporation of suggestions from readers since the past guidelines was published in 2012. They've continued using the American College of Chest Physicians classification scheme for grading evidence, which I'll talk a little bit more as we move along. And I'll talk about this more too, but evidence is pretty limited for lightning injuries because it's mostly just case reports and case series that have been published. So first, I'm just going to talk a little bit about some background with some lightning physics and physiology. So there's three elements that are needed to make a thunderstorm. So one, you need moisture, two, you need warm air on Earth's surface, and then three, you need a lifting wind. So what happens is that moist air is pushed up, creating cumulonimbus clouds. And then within those clouds, the ice particles form on top. And the movement of these ice particles creates the electrical gradient, which is what causes the lightning to get discharged. So there's four main types of strikes that can cause injuries. So the first one I'm going to talk about is a direct strike, which is pretty much what it sounds. So that's the image on the top right, where the lightning is directly striking the person right here. Another type of injury is called a contact injury, and that happens when a person touches an object that the lightning strikes. So in this picture, the person is touching the fence, then the fence was struck by the lightning. Another type of injury is the side splash injury, and this happens when an object is struck and the lightning splashes or jumps to a nearby person. So you can see that on the bottom right image. So it first struck the tree, and then the electrical energy then jumped to the person nearby. And then the other main type of injury is a ground strike injury. So in this example, in the bottom left, the lightning struck a tree. So it could either strike the ground or a nearby object, and then that lightning electrical current then travels and then strikes the person nearby. And ground currents are the most common type of lightning injury. And then followed by splash injuries. Splash injuries account for about a third of all injuries. So lightning takes a path of least resistance, and then within the body, the systems that have the least resistance are the nerves. So that's the path that the lightning strike would take preferentially. So then it just kind of goes in order up this way, and then the area in the body with most resistance would be the bones. So now I'm going to move on to some lightning epidemiology. So this image is taken from the guidelines, and it shows flashes of lightning per kilometer squared per year. So the dark red regions show where lightning strikes happen the most frequently, and they happen most frequently in Central Africa, and they occur year-round there. And part of the reason that they have such great incidences there is because of the mountainous terrain, and then they also get moist airflow coming right off the Atlantic Ocean. So worldwide, an estimated 24,000 fatalities occur due to lightning strikes, and about 10 times as many injuries occur. Populations that are most at risk are rural populations, particularly farmers due to occupational exposure and lack of nearby substantial shelter. So some trends in the US, there are about 40 deaths per year in the US related to lightning strikes. So in comparison, about 70 flood-related deaths occur annually in the US and about 30 avalanche-related deaths. So this image on the right, taken from the guidelines, shows fatalities in the US from 2004 to 2013. And the majority of lightning strike fatalities occurred in Florida, followed by Texas. And combined, those two account for about a quarter of lightning strike deaths in the United States. So over 80% of the victims are male. They're mostly aged 20 to 45 years old. And over 90% of the incidents happen from May to September. And in the US, there's a lifetime risk of getting struck by lightning is about 1 in 10,000. So now I'm going to move on to talking about some prevention strategies from not getting struck by lightning. So first, I'm going to talk about some behavioral strategies. So the saying goes, when thunder roars, go indoors. So if thunder can be heard, shelter should be sought after immediately. Although substantial shelter in the wilderness can be rare, individuals should avoid areas that are higher risk. So some areas include summits and tall objects such as ski lifts, cell phone towers, isolated trees. So it was previously recommended to time lightning flashes with thunderclaps to estimate the distance from the storm. However, they're no longer recommending that because the rule can give incorrect calculations, which can lead to also a false sense of security, or they could be calculated incorrectly given the certain lightning flash with the correct thunderclap. So instead, it's recommended that individuals should observe for changing weather that indicates thunderstorms. So this picture is like a very dramatic example of it, but 3 things you want to look for is cumulonimbus clouds, and they form vertically and then they kind of spread out more at the top. So it's kind of more of like an anvil shape. The skies will also darken and you could feel increased winds as well. So it's also recommended that people wait at least 30 minutes after hearing the last thunderclap to resume outdoor activity. And that's because 30 minutes should allow a proper buffer zone for the storm to be about 10 miles away. So behavioral strategies, like a lot of other recommendations I'll go through in this PowerPoint, was given a 1C recommendation using the AACP recommendation scheme. So what that means is there's strong recommendations, even though there's low quality evidence, because the benefits clearly outweigh the risks or burdens. And the data was taken from observational studies or case series. So these recommendations could change if higher quality evidence becomes available. So there's no absolutely safe place from lightning, but there are some places that are safer than others. So the safest places that you can be would be a building away from doors or windows, followed by a car with a metal top with the doors and windows closed. That doesn't include convertibles with fabric tops. So in the wilderness, usually substantial shelter is not available. So some of the safest places you could be instead would be deep within a cave, a dense forest, or in a deep ravine. Some exceptions to that would be shallow caves, solitary trees, or open shelters. So things like picnic shelters, dugout canopies, or lean-tos should be avoided because those areas would increase a person's risk of a side splash and ground current injury. It's also important to note that tents do not provide adequate protection either. So this is lightning positioning that can be used if a lightning strike is imminent. So the position can be seen on the left, and that was taken from the guidelines. So the position involves crouching with the knees and feet close together to create only one point of contact with the ground. So standing, it's important to have the feet touch, and if they're not able to assume this position and they're sitting, it's important to lift the feet off the ground. The person can also insulate themselves from the ground. So some examples could be sitting on a pack with all the metal removed, sitting on a dry coiled rope, or a rolled foam sleeping pad. And it's also important to note this position is a last resort and should only be used when all other lightning prevention strategies have failed. So some signs of an imminent lightning strike that a person can observe would be a blue haze around objects, static electricity over hair or skin, an ozone smell, and a nearby crackling sound, sorry. And the goal of this positioning is to minimize the person's risk of a ground current injury. However, it's only given a 2C recommendation because the evidence is low quality and it's uncertain whether the risks clearly outweigh if the benefits clearly outweigh the risks or burdens. So other alternatives may be equally reasonable. So for group safety, it's important to spread out all group members at least 20 feet apart. So lightning's able to jump up to 15 feet between objects. So it's really important for everyone in the group to spread out to avoid any splash injuries, to prevent mass casualties. All group members should also be aware of the group specific lightning safety plan. So the plan should account for local weather patterns, current forecasts, local terrain, and predetermined shelter and evacuation routes. So the goal is to have a pre-established plan that'll minimize chaos in the event of a thunderstorm. So some resources that can be used to develop a lightning safety plan are the National Lightning Safety Institute and also the National Weather Service. So there are lightning detection technology out there. There's several commercial services that offer notifications through text, email, or call when lightning is detected through the National Lightning Detection Network. However, that relies on cellular data, and that's not always available in the wilderness. There are some lightning detection devices that can be bought. The images on the right are some that are examples I found off of Amazon. So they claim to detect lightning up to 75 miles away. It's important to note, though, that these technologies have not been peer reviewed. There's only manufacturer testimonials to claim their efficacy. So these devices could be used to augment a lightning safety plan, but not take the place of, because it also only has a 2C recommendation. So if you're found in a mountainous environment and there is a thunderstorm, the saying goes up by noon and down by 2. And what that means is that peaks and ridgelines should be avoided in the afternoon. So also, if climbing while in a thunderstorm on a mountain, climbers should tie up individually. That avoids conduction of electricity through the wet climbing ropes. Individuals should also discard any metal objects that they can, like ski poles or mountaineering axes, to avoid potential contact burns. So if someone's found in a water environment in several different situations, so if you're swimming, you want to exit the water and find the best shelter that you can. Kind of similar with rafting or kayaking, you want to move to shore and away from the water's edge. And then if boating, it's recommended to lock off the helm and seek shelter below the deck. And if no shelter is available, it's recommended to tie into a lifeline. So now I'll talk about different injuries and treatments related to lightning strikes by each body system. So first I'll talk about resuscitation. So the mechanism of sudden death from a lightning strike is simultaneous cardiac and respiratory arrest. So initially, an asystolic arrest is caused by simultaneous depolarization of all myocardial cells. It's also possible to see VFib instead. Cardiac automaticity in the form of sinus bradycardia precedes recovery of the respiratory system. So the medullary respiratory center remains paralyzed, even despite a return of spontaneous circulation. It's also important that victims retain no residual electrical charge, so it's safe to touch victims. The recommendation is to use basic life support and advanced cardiac life support, which is given a 1B recommendation. So that's a strong recommendation with moderate evidence from randomized controlled trials that can be applied to most patients in most circumstances without reservations. And it also should be noted that death is rare should the person survive the initial lightning strike. So when there's multiple people, the reverse triage is the strategy that's recommended. So since return of spontaneous circulation precedes resolution of respiratory arrest, ventilation needs to be supported as soon as possible. So priority is actually given to those without vital signs or spontaneous respirations. And there are multiple cases of survival with intact neurofunction in victims who received immediate resuscitation. So that's why the reverse triage is recommended. Now moving on to the cardiovascular system. So effects can range a lot from benign EKG changes to sudden death. So cardiovascular collapse is more common with direct strikes, while transient EKG changes are more common with contact or ground current strikes. So some initial cardiovascular effects can include ST elevation, prolonged QT interval, cardiomyopathy, AFib, and elevated cardiac markers. And usually these initial findings resolve within 3 days. There is even a case study of someone who experienced cardiogenic shock that required an intra-aortic balloon, but cardiac function returned to normal 3 days later. However, some injuries can occur later, such as pericarditis or cardiomyopathy. There could also be autonomic instability in the future that can last for weeks to months after the event. So for cardiac evaluation, it's recommended that high-risk patients receive an EKG and an echo. So I'll be talking a little bit about each of these as we move through the different systems, but this is taken from the guidelines and it shows what indicators are considered high risk. So some of those include like a direct strike, loss of consciousness, chest pain or dyspnea. So those patients, if any of these criteria are met, it's recommended that they get an EKG and an echo. So cardiac markers are not recommended. And then the reason for that is because they're not prognostic and they don't correlate with anatomic lesions. So their clinical utility is limited. Patients with a direct strike or abnormal EKG or an abnormal echo, it's advised that they should be on telemetry for at least 24 hours. And discharged patients should return if experiencing new chest pain or dyspnea. So it's important to educate patients on that because there could be some delayed injuries that I talked about, like pericarditis or cardiomyopathy. So now I'm going to talk about the neurologic injuries, and there are several different categories that can be seen with lightning strike injuries. So the first one is transient neurological symptoms with immediate onset. And those ones are the most common. So signs and symptoms of those could be loss of consciousness, seizure, headache, paresthesia or weakness, confusion and memory loss. And then cranial paralysis is the next category. And that occurs from overstimulation of the autonomic nervous system. And that leads to vascular vasospasms. So typically the lower extremities are impacted more than the upper extremities with these. And signs and symptoms of those include lack of pulse, pulmonary cyanosis, any sort of motor or sensory loss in the affected extremities. And it actually usually resolves within hours, but something important to keep in mind when assessing these patients is that cranial paralysis could also mimic a pulseless victim. So it's important to also check a central pulse before starting CPR. And anyone who experiences cranial paralysis, a hospital observation is recommended because it could indicate a more serious underlying trauma, which is given a 1C recommendation. And that's because it could be mimicking some sort of spinal cord injury. So these patients should also have spinal precautions until a spinal injury is ruled out if neurodeficits are persisting despite a resolution of pulse or pulselessness. And that's given a 1C recommendation. So then the third category of neurologic injuries is permanent neurological symptoms with immediate onset. And those can occur from a few different mechanisms. So it could be due to hypoxic encephalopathy from cardiopulmonary arrest. The patient could have suffered an intracranial hemorrhage. Most often it occurs in the basal ganglia or the brainstem because those regions of the brain have preferential conductivity. Direct head strikes are also more likely to lead to permanent neurological symptoms with immediate onset. And the direct strikes to the head also have higher fatalities compared to indirect strikes. And that was reported in one case series. So some less common permanent neurological symptoms could be peripheral nerve lesions, cerebral infarct, cerebral salt wasting syndrome. And for all of the permanent neurological symptoms, treatment's really focused on long-term rehabilitation. So then the next group of neuro injuries that can happen are delayed neurologic syndromes, which is progressive myelopathy resulting in weakness or sensory loss, which can occur weeks to months after the initial injury. And the highest incidence of damage in the spinal cord is in the cervical and thoracic regions. It's recommended that if any victim experiences delayed neurologic syndromes, that they should follow up with a neurologist as soon as possible. And that's given a 2C recommendation. And then the last category of neuro injuries is central nervous system injuries associated with secondary trauma and blast effect. So victims with loss of consciousness or persistent abnormal neural findings should receive a head CT, and that's given a 1C recommendation. So the next group of injuries is dermatologic. So I got this image from a case study I found that was published of a couple that was simultaneously struck by lightning in Florida. So the first finding I'll talk about is the Lichtenberg figures. And these are the feathering patterns you can see. You can really see it in image C. So these Lichtenberg figures, it's not a burn pathogenesis, although it remains controversial. So they typically present within 1 hour of the lightning strike, and they're actually gone by 24 hours. And no histological change or damage on biopsy is usually shown with these Lichtenberg figures. However, pigment changes in the deeper layer of the skin may persist. But presence of these Lichtenberg figures requires evaluation for any other possible effects of lightning, which is a 1C recommendation. So then there are 3 different categories of burns that can be seen with lightning injuries. So the first one is linear burns, and these are partial thickness burns that happen when sweat on the body is vaporized. So it's also called a flashover injury. And it usually occurs in the sweatier regions in the body, like under the arms and beneath the breast. So in picture B, you can see with the dark black arrow, you can see an example of the linear burn. Another type is the punctate burns. So these are clustered circular burns, and they're thought to come from current passing out from the underlying deep tissue. And a sign you can look for with these, it's called the tiptoe sign. So you could see small full thickness burns at the distal toes or at the sole of the feet. So examples of punctate burns can be seen with the white dotted lines in this picture. So in picture B, there's one right there. And you can also see one right there on the thigh in picture A. And then the last category of burns is full thickness burns. So large full thickness burns tend to happen anywhere the skin is in direct contact with either metal or synthetic fabric. So the synthetic fabric can melt onto the skin, or a metal object can get heated up by the electrical energy caused by the lightning strike. So skin grafting is pretty uncommon with lightning strike burns. So in a case study of 16 patients, only 10% required skin grafting who were treated at a burn unit. It should also be noted, though, that cranial burns led to a 3-fold increase in mortality, and these patients were also twice as likely to undergo cardiac arrest. And then in a limited case series, superficial burns that involved less than 20% of the total body surface area tended to heal pretty quickly and could be just treated with routine burn care, which is a 1C recommendation. And then if anyone is caught in a thunderstorm, it's recommended that they remove any metal objects from themselves. So that could be watches, belts, jewelry, to avoid these type of burns. And that's given a 1C recommendation. So the next group of injuries is eye injuries, and they're pretty common, which also makes sense if you think about how innervated the eyes are, and lightning strikes prefer to go through neural pathways due to their low resistance. So it can affect both the anterior and posterior chambers of the eye. The lens is also commonly injured, and cataracts make up the majority of those injuries. And usually they're bilateral, but the exact incidence of the cataracts are not known. But they tend to develop between 2 days and 4 years after the initial injury. And there's several mechanisms that the eyes can get damaged during a lightning strike. So it could be a current passing through the lens, some blunt or blast trauma, vasoconstriction or heat. And it's recommended that those who had a high-risk lightning strike or anyone who had any sort of vision loss after a lightning strike see an ophthalmologist, which is a 1C recommendation. So the next group of injuries is the ear. So tympanic membrane rupture is pretty common. In a case study, over 60% of subjects had suffered a rupture, which also makes sense too because it's highly innervated, so it's a low resistance pathway. So rupture can occur from either blast trauma or the electrical injury. However, uncomplicated tympanic membrane rupture usually healed spontaneously. It's also important to assess for otorrhea because that could be a sign of a basilar skull fracture or secondary trauma. Sensorineural deafness is common and is usually transient. However, permanent hearing loss is possible, and that could occur from microhemorrhages or microfractures that occur to the deeper structures of the ear. So it's recommended that all lightning strike victims get an evaluation of their tympanic membrane, and that anyone with hearing loss should follow up with an otolaryngologist. So there can also be psychiatric and neurocognitive deficits after a lightning strike, and those are broken up into two categories of functional deficits and behavioral deficits. So the functional deficits include things like memory, concentration, and problem solving. And then behavioral problems can also be seen that include depression, sleep disturbances, emotional ability, and also aggressive behavior. So it's important to recommend to victims of lightning strikes and their families to observe for these behaviors. There's actually an organization that offers support through counseling and long-term sequelae of lightning injury, and they're called the Lightning Strike and Electric Shock Survivors International Incorporated. So I have all of their information here that was included in the guidelines, and I also included their logo that I found on their website. So its symptoms should arrive that are either psychiatric or neurocognitive in nature. It's recommended that the victims receive specialized care from a mental health professional. So pregnancy data is pretty limited. There's only 13 cases that have been reported. So maternal mortality is low, it's at 0%. However, fetal mortality is at 50%. And that's thought to do because the amniotic fluid is highly conductive. And lightning strikes can also lead to either uterine rupture or induction of labor. So it's recommended that pregnant persons more than 20 weeks gestation need to be evacuated so that they can have a lightning associated injury screening and also fetal monitoring. However, it's not recommended for pregnancies that are less than 20 weeks gestation to be evacuated because the fetus is not considered viable at that point, so no fetal monitoring is required. So disposition and evacuation. So safety is first and foremost, so the state needs to be determined safe before rescuers can assist. And victims with high-risk indicators should be evacuated first. So I've touched on quite a few of these within each body system, but any of these criteria, these people are going to be prioritized. And then anyone else with lower risk injuries, they'll be triaged based on the extent of their injury and then their overall medical condition. So in conclusion, the summary recommendations largely are unchanged since 2012, even with more case studies being reported. So most new and old available data is based on small retrospective case studies. Prospective case studies of lightning injuries aren't logistically or ethically feasible. So recommendations generally are strongly reported. Most of the recommendations had a 1C recommendation, which is even though the evidence is limited, it appears that the benefits clearly outweigh the risks or burdens, even though they come from case reports and observational studies. So then at the end, the authors also called for improved reporting to a national or international database. And the reason for that is because they think it could help with future epidemiological studies. And they also called for a desired consensus on injury classification systems, which would simplify the reporting process and also allow for data to be more easily combined for future studies. Okay, so then that's just my references for some of the images I found. And then I'll take a look at the chat and see what questions there are.
I was mostly just doing like conference busy work stuff.
Oh, okay.
But yeah, do you, as I mentioned here somewhere, she Julie basically covered every lightning-based question that was on our DIM test that we took. If for anybody that did the pre-conference summer DIM session test, every question that was on there was just covered. This is definitely a topic that probably most people don't know about. I personally have never taken care of a lightning strike patient. Has anybody here taken care of a patient involved in a lightning strike? Seen a patient struck by lightning, anything? Okay. So that's kind of why we like to do this kind of stuff. Any questions for Julie? Oh, wait, we got two, Drew and Jeff. Can you tell us about what you encountered?
Yeah, we had at a fairgrounds nearby where I'm a paramedic, and we responded out there that somebody that had one of those like associated strikes. It struck nearby, traveled through the ground, and hurt the folks, but they weren't. We had no evidence that we needed to perform any kind of spinal motion restrictive. They weren't thrown. There was no cardiac dysrhythmias involved and no burns. They were just kind of felt the sensation and absolutely knew that they were struck by lightning, but they didn't have any serious mechanisms of injury or anything else. They were transported to the hospital and ultimately discharged soon afterwards.
And Drew, what did you see something similar, or did you have a different encounter?
Oh, I was on the receiving end of that situation of, was it a bald roan? I think getting it right. Storm came up on us and had to hunker down essentially in the deepest crack we could find. And I got the splash from the rock next to me. Got thrown, but nothing long term. Kind of packed it out the next day because generally just sore all over.
I haven't encountered it personally, I guess. About any questions for the content from the guidelines presentation? All right, before we move to the next one, like I was saying in the chat, I'll email everybody as well. So fellows are now also active fellows, and anybody who was a fellow during any of the prior journal clubs can now submit for FOM credit for those sessions they've attended. I'm not sure why that was not the case prior, but now we can do that. Other than that, so basically still, if you're anybody in training, essentially, from medic, EMT, PA, NP, med student, resident, fellow, basically any student can get free credit for this course. I think that covers about every student I can think of. So with that being said, I'm going to try and get the WMS to give me access to the FOM fireside chat. That's what they call their like webinar series when they talk about different programs, and I'll email that out too, because I get quite a few emails about the FOM, and I think it would be a good thing to listen to understand more about the program itself. With that being said, this is the lightning topic, and let's stay on that. We're going to move on to the articles. Ken or Alex, one of you want to go first?
I can go. I don't mind.
All right, go ahead.
All right. How does that look?
Looks good.
All right, so my name's Alex. I am a current emergency medicine resident up in Michigan. I am going to be presenting one of the articles. It's the case report of the lightning strike in pregnancy with fetal injury. This was authored by Dr. Skalster, Hodnick, Berkeley, out of the University of Nevada, published in 2016 in the Wilderness Environmental Medicine Journal. So the case is that it was 4th of July in the Southwest United States. There was a family that was packing up because they heard a distant but rapidly approaching thunderstorm. Witnesses saw a sudden bright flash and an earth-shaking boom, and then 2 of the family members were found to be unconscious on the ground but breathing. Bystanders called 911, and the local fire engine was about a mile away, actually dealing with another, so that was lucky. So the engine was the first to arrive to the scene. The paramedics were close behind. It was deemed that the scene was relatively safe. There were no immediate hazards or fire. They found the 2 patients on the ground, one being a 22-year-old female currently pregnant, and then a 32-year-old male. So the female had some like patchy erythematous lesions on her chest. She had a small lesion on the tip of her thumb, and then she was complaining of low back and low bilateral calf pain. So it would appear that by the time that EMS arrived that they were actually both awake, alert, and oriented. So they eventually came around. The 32-year-old male had left ear pain, some hearing loss, and drainage from the ear. He was complaining of numbness and tingling in his extremities and pain in his feet. He also had some erythema on his chest as well as singed chest hair, and then erythema on his flank and calves. So both patients were rapidly transported to a level 1 trauma center. When they were en route to the hospital, they did a more thorough exam, didn't find any additional injuries. Both were noted to be tachycardic, like 102, 105, I think were the 2 heart rates. And I think they even did like a 12 lead and didn't note any ectopy or arrhythmia. So on arrival, I'm going to focus on the female patient now. On arrival to the emergency department at around 10 o'clock p.m., of course, you think about your ABCs, right? So airway was found to be patent, normal phonation. She had equal breath sounds bilaterally. She's a little bit tachypnic at 22, but not in any respiratory distress. She was, again, noted to be tachycardic at 116 with normal heart sounds, good distal pulses, and well-perfused skin. For disability, she had a GCS of 15 and symmetric movement in all of her extremities. And then for exposure, they noted that she had some mildly damp skin that they attributed to the rain. So on their secondary survey, in the article, they go through each system and list out all the normals. I'm not going to read that off, but I guess what would be pertinent is for HE&T, she had normal TMs. Exam of the abdomen, she had a gravid uterus above the level of the umbilicus, which is important, right? Because that means she's at least 20 weeks and therefore there's a viable fetus there. The abdomen was soft and non-tender, which to me, I guess means less suggestive of like blunt injury. Her neuroexam was normal. Her skin was again noted to be damp but warm, and there were no rash or lesions noted per the article. They did do a bedside fetal ultrasound, which showed a fetal heart rate of 155, which is appropriate, maybe a little fast depending on what source you look at, but for our sake, we'll say that's normal. And so OBGYN was consulted anyway, which was also appropriate. And then they noted that after about an hour, the patient's skin developed these odd lesions on her right flank and right thigh. So obviously this isn't our patient, but I borrowed this from a case report in the New England Journal of Medicine. So OBGYN is monitoring. She, at around 1:30 in the morning, it was decided that she would go to emergency C-section because of what I imagine of fetal heart tracing that looks something like this. So the baby is noted to be tachycardic. This isn't really tachycardic, but you'll notice that there's not very much variability in the fetal heart tracing in the top. So you should see like variability in that top line, and that otherwise it's a bad sign. So they also noted her to have a biophysical profile score of 2 out of 10, which if you're like me and didn't know what that meant, this is kind of what they look at. So they're looking at fetal breathing, movement, tone, and then the amniotic fluid volume, and again, like the presence of those accelerations versus no accelerations or minimal variability. So this fetus scored a 2, which means almost certain fetal asphyxia and delivery recommended. So that is why they went to C-section. So in C-section, they delivered a 2.8 kilogram female infant, which is a little over 6 pounds and appropriate for that gestational age. APGAR scores not so great initially, 4 and then 7. The neonate was transferred to the NICU for respiratory distress, depressed neurostatus. They were given phosphoenitoin for periodic shaking episodes. Obviously, the concern there is that they're having a seizure. EEG that was done on day 1 showed abnormal burst suppression and diffuse cerebral dysfunction, which sounds bad. I looked it up anyway, just to kind of for my own learning, and burst suppression can be the result of a lot of different things, like coma or epileptic encephalopathy or medically induced coma, but you know, obviously in this case, not good, you know, associated with adverse outcome. They also did an MRI on day 2, which showed ischemia of the bilateral symmetric posterior limbs of the internal capsules. And then the article noted that, you know, this lady had multiple previous prenatal visits, including 3 fetal ultrasounds, and there was nothing abnormal. And nor was there any family history of any congenital aberrancies or anything that would, you know, have predicted this. They did do an EEG a couple of weeks later, which did show improvement, but still not great. And they were diagnosed with diffuse cortical injury and failure to thrive. 1 year later, at a follow-up, they were noted to have marked developmental delay, unable to sit up, crawl, or swallow, and requiring a feeding tube, like a D tube. So mom was discharged on post-op day 4, no complications, although she did have persistent spasms in her low back and calves. And then she developed new onset depression at 3 weeks postpartum. The male patient that I mentioned, they did briefly say that he was discharged after a couple days and had some issues with vertigo. No surprise, had a ruptured left TM, so otherwise doing okay. So the authors of the article chose to focus on a few different topics related to lightning injury. So I will go over those. Julie did a great job of going through a lot of these, so I won't belabor the point, but one of the things they focused on was the comparison of lightning versus other high voltage sources. That table is from Auerbach's chapter on lightning injuries, but I think it does a good job of summarizing some of the points that the article made. So basically, you know, lightning is neither AC or DC current, but it's, if you're going to compare it to something, it's most like DC. The magnitude of the volts is much greater, but the exposure is on the order of milliseconds. So you're not going to see, you know, those deep like internal burns or tissue breakdown. You're going to get those flashover type burns. And because of that, you know, these patients don't often require aggressive IV fluids or, you know, things like fasciotomy. And also they made a point to say, most commonly you're going to see asystole after lightning strike. With prolonged exposure to current, you might be fib. So that's also a possibility. What else here? So you could also get like blunt injury, more likely with lightning injury because it propels a victim from the source, kind of like DC current would do. So there's a greater risk of blunt trauma with that. And then the other kind of unique thing, I guess, with lightning would be coronal paralysis. So I won't really talk about that anymore because it's already been discussed, but that's also unique to lightning. They also focused on the different injury patterns. Again, I'll kind of breeze through this, but these are from Auerbach's chapter as well. So you have your linear burn patterns. This is from a baseball player. So you see the burns there in the antecubital fossa and then kind of like following the line of sweat that maybe was dripping down his torso. These are punctate burns. The young girl that was at a campfire and got struck. And then those are the kind of lesions on her shirt that were overlying those areas. Here's your Lichtenberg pattern, which is not really a burn, but it's just unique to lightning. I think it's from like red blood cells that are extravasated into the tissue, kind of like a bruise would be. And then here is a thermal burn type. So when you get that flashover kind of injury, if there's any sweat or like water or anything on the surface of the skin, or metal or any kind of thing that could vaporize or heat up really hot, you can get thermal burns. So this hiker's boot was wet. And so he unfortunately sustained thermal burns to his foot. So once again, primary cardiac arrest is a possibility with strike. Asystole is most common. And then of course with stunning of the respiratory drive, you can get secondary cardiac arrest, which is due to hypoxia and ventricular dysrhythmia. So the take home point there is reverse triage, which we have already discussed. The authors go into kind of a long list of different types of morbidity that someone could suffer after this type of injury. Most of them are effects on the nervous system. So anterograde amnesia and confusion are pretty common. This can last for up to days, so they're not able to form any new memories. Patients can also get paresthesias, muscular spasms like our pregnant mom. They can also get post-traumatic headaches, which can last for months. They could get chronic peripheral neuropathy, motor skill dysfunction, chronic pain syndrome, sleep issues, and then like neuropsych issues with like depression or PTSD, which again could just be postpartum depression, but it's a possibility that this was precipitated by a lightning injury. I guess travel of electrical current through the brain can cause epidurals and subdurals or interventricular hemorrhages as well. And of course, if you're thrown from the strike, you can get blunt injury, which can cause all those things. And then blunt injury from fall or blast can cause all sorts of, extremity torso injuries. And then of course, like the ruptured TM. And then you can actually even get like lung injury from the blast. So like pneumomediastinum or hemopneumomediastinum. So plenty of things to go wrong. The authors talked about kind of the briefly about a chart review that they did. They said that previous to their article, there were only 13, this being the 14th report of pregnancy affected by lightning strike. In 5 cases, there were intrauterine fetal demise. In 1 case, there was death of the newborn. So they were alive a few hours, I think, and then died. This is the 1 case of long-term morbidity. And then there were 7 cases where they survived. And then they also looked at major news sources and found an additional 7 cases. 6 cases, again, survived, no long-term morbidity, no problem. And then 1 case, there was actually death of the fetus and the mother because they were taking shelter under a tree, which I presume fell on them. They didn't really go into that, but so overall, 21 cases, 13 survived without any long-term issues. So if you look at that, the flip side, that's like a 40% morbidity mortality for the fetus, which is pretty high. So this is kind of my summary of some of the, I think, the important take-home points of this article. Obviously, this is like a one-of-a-kind case report. It's the first case of a significant fetal morbidity being diffuse ischemic brain injury. I think they kind of want to make known the importance of rapid fetal assessment and monitoring, given the risk, the clear risk of unborn fetus. And then this is also supported by our WMS guidelines that pregnant women are high risk and should be evacuated, immediately and get screened and all of that. We know that 3rd trimester is greater risk. The authors of this article didn't really try to guess why, but like Julie said, could be related to the fact that amniotic fluid is highly conductive. And then they talked about how, given that the data set is limited with this particular patient population, that lightning-associated injuries in pregnancy is probably a lot lower than what's in the medical literature. So these are just some of my thoughts on the article. With it being a case report, that's a little bit different when you critically appraise the article. But I was kind of thinking as I was reading through the guidelines and like Auerbach's chapter, about how, so first of all, I guess being like scene safety. So the paper says there were no immediate hazards noted, but I think it's important to remember that, these scenes really aren't really ever safe, I don't think, because like 1/3 of lightning casualties occur as the storm is approaching because people misjudge, how fast the storm is coming. And then 1/3 of injuries or victims are struck at the end of a thunderstorm because they went outside too soon. So that's, 2/3 of strikes occur before or after the storm. So I think that's significant. So just remember that if you ever are responding to something like this. Lightning can travel, 10 miles or more. So even in a blue sky, you could get struck. So I guess the take home there is if it's possible, you should probably try to get the victims out of this area as soon as possible. Other thing I was thinking about was like scene clues. So like I kind of wish that they had talked more about what the scene was like, what kind of terrain it was, how far apart were the two family members. Was there anything nearby that could have increased their risk of, like side splash or ground current? I just think it would have been like an interesting thing to include. Maybe they didn't have that information, but would have been interesting, I think, to include. And then also, just kind of thinking through like, they said that the vital signs were normal, but I think it's important to note like temperature, for example, is really important to note in these patients because, they're struck during a thunderstorm, so they might be wet, they might be cold. Hypothermia should be anticipated and treated appropriately. So much as a criticism of the article, but just to remember that that's an important vital sign in these patients. And then blood pressure as well. So again, we're reported as normal. But like, let's say you have someone that doesn't have pulses in their feet, and it's important to differentiate or distinguish that from something like chronoparalysis versus true hypotension. Like Julie said, like, is it spinal shock, or do they have a blunt injury and they're bleeding out in their abdomen? So really making sure you get a solid set of vital signs. And then also an EKG, they just said that they were tachycardic. I assume sinus because the rates were so, they're barely tachycardic, but it would have been interesting to know, was there QT prolongation? Was there T-wave inversion? Was there any kind of abnormalities that you might see with a lightning strike injury? And then I guess the last thing that I was thinking about was, you might have noticed this, like the injuries that EMS reported were different from what they found on their primary and secondary survey. So they didn't note like the burns on the chest or flank or thigh, or like the lesion on her thumb. So just something I noticed. And I think that is everything that I have. These are my references, mostly images. And thanks for listening.
Any questions about that article? Or any comments on the case or the care of the patients in the case?
Yeah, I had a question. I'm sorry if I missed this, but what did it say what the gestational age of the fetus was?
Yeah, 37 weeks and 5 days.
Okay.
Yeah, it was somewhat of a rather depressing article, so sorry about that. But I think it drives home the topics brought up in the guidelines and then kind of delves into them. And she was going over some of the updates One nice thing about this article is it talks about cases that have been documented since then the guidelines were written. Like the guidelines mentioned 13 cases of pregnant women being struck, I believe, and then this one delves deeper and finds up to 21, I think. So it was just kind of nice to see further details since the guidelines were published. I'd say it kind of further deepens the knowledge of the guidelines, which is kind of why I choose the articles. Sometimes I choose like true research based articles that I want to have you learn about, like critiquing, and then sometimes just cool cases to learn about too. So that's where this one kind of fell. Any questions about the physiology in the case? Why do you think there were some things noted by the paramedics that once the patient got to the ER noticed a lot more? Why do you think that happened?
Well, the ER actually noticed less, it seemed like, because the EMS noted like the erythema and the singed hairs and like the 5 millimeter lesion on their thumb, for goodness sake. Like they noted all of that. But the ER, like it literally said in the article, no rashes or lesions or something identified. And then later is when the Lichtenberg figures showed up, like an hour later, which that's not surprising because that's like a known thing to happen.
Mm-hmm.
But I was surprised that they didn't comment on the like the burns, the superficial burn, because I wouldn't expect those to go away during transport.
It was probably July.
Or macros in the electronic record. Those
Yeah,
will get you
somebody
every
was
time.
clicking a macro in Epic, or
I
maybe
hate them.
So there is kind of cool thing about lightning is some things show up right away and go away rather quickly. Some things come about hours later and then go away within about a day or so, and some things you get within a couple months. So I think that's probably got part of the explanation, or it's just actual medical practice where there's macros, or you're rushing off to a trauma or a code or something like that. That's what's kind of tough with case series and case reports, but you go by what's written. I thought it was kind of interesting that they were trying to pin the mother's depression on the lightning when she had just had been struck by lightning herself, had her child have requiring emergency delivery, and then like failure to thrive requiring G-tube. And I was like, I feel like that's probably the more likely cause, but yeah, you can say it's from the lightning if you want.
Yeah, well, you never really can know, I guess. There's multiple explanations, agree.
Yeah, it's kind of when you take it into context in other cases too. All right, so that was more of a case report, single, I guess 3 patients technically. The next case is a bit more broad, more of like a search and rescue MCI type thing. But Ken, whenever you're ready, take it away.
Just one moment. I have to change my settings. It's not letting me share. There we go. I'll be right back.
Alex, I can't remember if I asked, where are you at in Michigan? Which program?
Western Michigan, Kalamazoo.
I think I did ask you. So that's Bronson or Borges?
It's both. We
Both.
alternate between the two, which is pretty cool.
Yeah.
You were over at Henry Ford, right?
Yeah.
Yeah.
And Danielle, you were from up in Michigan as well, right?
Me?
Yeah.
I'm in New York.
New York. Okay. I'm trying to keep. I slowly learn everybody who joins the series, but sometimes it takes a while. There we go.
All right, there we go. So lightning injury. So my name's Kenny Hunt. I'm a fourth year student at the University of Queensland's Ochsner Clinical School. So I did my first 2 years of training in Australia, and then my second 2 in New Orleans, Louisiana. All right. Okay, so real quick introduction. The title of this article is Lightning Multiple Casualty Incident in Sequoia and Kings Canyon National Park. And the objectives, as you can see here, review the response to a lightning caused MCI, multiple casualty incident in a wilderness setting, address field management of lightning injury, discuss evacuation from remote locations in inclement weather. All right, so a little bit of background, published in Wilderness and Environmental Medicine. And then 3 of the 4 authors were emergency physicians at the receiving hospital for the critically injured patients. So this was University of California, San Francisco in Fresno, so UCSF Fresno. And then why this is important, lightning injury, second most common cause of storm-related deaths in the US. That's second behind flash flooding and what's already been touched on. About 400 people affected with 40 deaths annually. And then for this report, it's just the location, weather, and number of victims really just makes this a really unique case. So the study, it's a report detailing a lightning strike that hit a Boy Scout troop of 12 in Sequoia and Kings Canyon National Parks, and abbreviated SECI, and in July of 2005. It was 5 adults, 7 adolescents, all males. The adults were aged 29 to 57. Adolescents were 12 to 17 years old. And so this study really covers the outcomes, morbidity and mortality of the 12 victims, and then the bystander and EMS response. So it's a little bit bigger picture rather than specific treatments. And then I just want to throw this in here with the bias that UCSF Fresno provides all the medical oversight and training for these park medics and EMS. So potential source of bias there. All right, so the method, it was compiled using information from Freedom of Information Act requests of the National Park Service, and then First Hound's account of everyone there. And just notably, this took place in 2005, and then it was published in 2015. So with those firsthand accounts, maybe a little bit, not fully reliable. All right, so the case. So this is where they started the backpacking trip. They were 53 miles in at the accident site near the base of Mount Whitney in California. And they're at 10,600 feet at a meadow. It's called Sandy Meadow. And then I'll get into it a little bit further, but essentially when the troop saw the storm coming, the group of 12 broke up into smaller groups, and this kind of lays out where they were. And then this shows the foxtail pine, 55 feet tall, that was actually struck by the lightning in the proximity to Tarp 1. And this was an actual picture of the tree that was struck by that lightning at the time. All right, so this is kind of a crazy scenario. It seemed very hectic, so kind of wanted to break it down into a little bit of a timeline before getting into other details. So 3 p.m., they started to notice the storm. That's when they broke up into those groups. And then 4:10 in the afternoon, that's when the lightning was hit by the tree. And immediately after that, a couple of scouts ran to a backcountry ranger station, reportedly about a mile away, and were able to get the ranger to call for helicopter medical backup. And by 5:10, so an hour later, rangers and scouts are back on the scene. 5:43, the first paramedic arrived via helicopter, and then 6:22, second park medic arrived, also via helicopter. And these helicopters landed and immediately took off just because it was too dangerous to stay and try to evacuate any victims of the scenario. And then unexpectedly at 6:30 p.m., 4 helicopters arrived. And I'll touch on this a little bit later, but it was unexpected just because communication was so poor from ground radio to the helicopters because of the electrical activity of the storm. And then 8:35 p.m. scene was cleared by 4 helicopters and then 2 ground ambulances, which were eventually able to get in and evacuate the victims. So this details everyone that was affected. So all of the scout members. So I wanted to highlight the 2 casualties, adult 1 and juvenile 3. So for adult 1, he received 90 minutes of CPR in the field before being pronounced dead on the scene, and this is his clinical evaluation. Juvenile 3, and these were both under TARP 1, as you can see as well. He received 90 minutes of CPR, found to have a carotid pulse of 20 to 30 beats per minute after the 90 minutes, however, still apneic. At that point, received 1 milligram of epinephrine, and his repeat pulse was 100 beats per minute. They were unable to get a blood pressure at the time. And he was being given oxygen supplemented through bag valve mask, and then flown to a regional trauma center. Sadly, went into cardiac arrest 2 days later in the ICU and passed. And then the 2 others, adult 4 and 5, these were the 2 other people who were seriously injured at the time. They were adult 4, initially actually received CPR, but made a full recovery later on. But he was the one they were initially trying to get to the helicopters when they took off immediately. And this was due to the miscommunication or lack thereof because of the storm. And then adult 5, again, had prolonged unconscious for about 10 to 15 minutes. And then I think rather remarkably performed bystander CPR after it was all said and done, and ended up making a full recovery. The other victims, minor injuries, a few here, 1st-degree burn on the back. A few of them were knocked unconscious by the strike, 2nd-degree burns and lymphedema, but everyone did make a full recovery. So for discussion, I wanted to re-mention the objectives. So the objectives were to review the response to a lightning-caused MCI in a wilderness setting, address lightning as it relates to field management, and then discuss evacuation options in inclement weather in these incidents occurring in remote locations. So appropriate actions taken by the scouts. They avoided the open meadow that they were in. They broke off into the trees. They also broke up into groups, which allowed the bystanders to get help and provide immediate treatment. So that really may have ended up really helping them out and saving some people. Some, I guess, inappropriate actions you could say of the scouts. The TARP 1 was anchored with parachute cord right to the base of the 55-foot tree. And apparently that this was one of the tallest trees in the area. So something that could have been avoided. And then they believe, due to how the burns were, that they're either sitting or lying directly on the ground rather than instead of that lightning crouch that was discussed earlier tonight. So the triage, which was already touched on again earlier, should be triaged using reverse triage principles. So rather than having a victim in cardiac arrest, resuscitation would not be attempted, just so those resources could be provided to the people with the best chance of survival. However, this is believed to be, I should say, opposite in lightning injuries, and that you should put efforts and resources into resuscitating them because they have a high likelihood of survival if you survive the strike. So overall, believed to be done, the troop overall did this correctly, and the EMS as well did this correctly by putting in the efforts into resuscitating those 2, adult 1, juvenile 3. So treatment, higher chance of successful resuscitation, as just mentioned, for cardiac arrest caused by lightning strike compared to other causes. But there's no good evidence to suggest longer resuscitation time should be used for lightning strike victims. And then transport, air medical transport by far the most feasible. They're in a very remote area. And although ground ambulances were eventually able to get there, aeromedical is really the only option. I think overall performed reasonably, but with a possible few areas of adjustment, primarily communication with the people in the air, but that was limited just by the fact that the radios they had were interfered with by the storm. And primarily I'm thinking about possibly could have organized transport of adult 4 who was minimally responsive, non-ambulatory at the time, but they just couldn't get that organized and figure out because of the breakdown in communication. So communication, the park medics on the ground had low frequency radios, which were unreliable in the storm. And the aircraft had very high frequency radios, so they could communicate with incident command who were able to tell them that there was going to be a break in the weather. And that's why four helicopters were able to land quickly in a row and evacuate the scene. And it could have gone smoother had they known those helicopters were coming. So redundancy in communication is key. And possibly most important aspect of a successful rescue. And I think worth mentioning is that this was in 2005, and now the cornerstone of backcountry communication is satellite devices, which would not necessarily be affected by the lightning, and nowadays would be able to communicate easier. So limitations, this was a case report in a very unique scenario, but highlights a lot of what we've touched on in terms of lightning injuries. So conclusion, communication is key. The lightning induced MCI should have utilized reverse triage protocol, which was done. And then I think consider further research into triage protocols in remote settings. It's obviously something that's very difficult to study, but could be important. And then I think this highlights the importance of having a plan, knowing the guidelines, and just understanding, you're not trying to make a plan in the moment, but really knowing that if a storm's coming, you're going to break up into groups. You're not going to be by large prominent trees. I think this highlights that really well. And that's the citation. Thank you very much.
Well, what do you think went well with what happened in the case and what didn't go well?
I think overall it went really well. They broke up into groups and the scouts were able to get to the ranger station and call for help. And they were lucky that the storm had a break in it and they were able to get 4 helicopters in quickly, and they're able to evacuate the scene, I think, in a relatively quick manner, given where they were, given the setting. I think the biggest mistake or didn't go so well is just when they initially broke off, it seems like they didn't maybe go far enough away from the meadow, and that they, like essentially set up that tarp at the base of one of the taller trees in the area. I think that was the main, otherwise I think they did really well. And then the communication was a little bit out of their hands given the technology that they had at the time.
Yeah, I think it's kind of hard to rip apart any communication errors when that's how people communicated with the equipment they had. I think they did very well with the helicopter usage, and getting the Boy Scouts to run off and find the Rangers so fast. That was pretty remarkable. I think if the Boy Scout group hadn't been separated into their different pavilion areas, probably would have been different, because they could have had the ground current between all the different strike victims that could have knocked them all out. If you see all the the History Channel, like the alien shows, when they find like the mass deaths of cattle, a lot of it is from ground current strikes to a herd. And unfortunately, things like that can happen to people too. So that could have really happened with this scenario if they had not been spread out. They could have potentially done a better job of spreading out. They still were huddled. It doesn't sound like they all followed like the lightning strike recommended crouching position. I think one of them had burns indicating that they specifically did not crouch correctly. But Douglas here posted this about communication. Anytime I've been in an MCI training exercise or a simulation in the field, it's always comms. And in the ER too, or whatever realm of medicine you practice, miscommunication kills, which is why you, in med school, PA, whatever ACP, paramedic training you're in, communication falls apart every time. Any other ideas about the case? Things could have been improved or done differently? I think it was pretty well documented case report, just, and they followed a reverse, essentially a reverse triage, I suppose. They knew to keep working on the people rather than just like call it. So I think it went pretty well. Any more comments before we move on to our own little MCI?
Yeah, I'm not familiar with the scout system in the US or what scouts are exactly, but I was impressed that they knew to do CPR and that they did any sort of splitting up and following of kind of lightning recommendations, being teenagers and all.
Can you remember what level of scouts they were? Does it say?
I don't think it says what level of scouts they were.
I mean, I stopped at Weeblo, which is barely above Cub, and then you get to Boy Scouts and then Eagle Scouts. But if they were Boy Scouts, they would be, I think, middle teenager area. I don't know. Boy Scouts are usually typically pretty well, somewhat mature for a group of guys in their teens. I think if it would have just been some random group of pre-teens or early teens, it would have been different too. All right, well, Danielle, whenever you're ready, take us through this MCI.
Cool. So is it showing as a presenter view to you guys?
Yeah, good.
Okay, cool. Yeah, thank you all to all the other presenters. That was all great and covered some of the stuff I was going to cover. So my name is Danielle. I am a third-year emergency medicine resident up in New York, although I'm originally from Bermuda, which has more lightning, being a subtropical climate, but I don't think there's ever been a recorded lightning death there. We are going to talk about MCIs, specifically lightning, but we'll do a little bit about just general MCIs, mass or multi-casualty incidents, where we produce multiple casualties, basically that the demand is greater than the resources. Generally, this is 5 or more patients, but it's any incident where the resources are overwhelmed. This picture is actually of a volcanic eruption in Chile that produced lightning, which I thought was pretty cool. So when an MCI or disaster happens, we've developed multiple systems to help organize the response. In the US, it's called the Incident Command System, which is a nationally recognized approach using standardized terminology and procedures. The incident commander is always the one on top. They're the first rescuer on scene and they're in charge of the overall incident. They can change if a person more qualified arrives. Of note, it's been shown that physicians are actually not best suited for this role. They should be in the medical unit, specifically in the treatment areas, which we'll focus on. This structure that you're seeing here is obviously for a major MCI with a major response and a lot of responders. So it's different depending on how many responders you have and how big the incident is. This is a little smaller, just a medical unit where the incident commander would oversee 5 leaders. The triage leader, it triages the patients on scene to one of 4 color-coded areas for further care. This again is not recommended to be an EM or IM or surgery physician because they're less efficient at triage and they're more likely to attempt heroic measures that are not appropriate for the MCI scenario. The extrication leader facilitates movement of the triage patients from the scene to the color-coded treatment areas, where the treatment leader or multiple treatment leaders, if you have enough, will treat the patients. The transportation leader coordinates with dispatch regarding patient transport and maintains the patient identification triage tab steps. And then the dispatch leader relays the information between incident command and coordinating hospitals. So this would kind of be the ideal setup for a medical response MCI. If you have less people, you can kind of combine roles like this. And then if you have even less, then the incident commander just does everything. So the most common triage algorithm used in the US is the START algorithm, which stands for Simple Triage and Rapid Transport, used for people 8 and up. It was actually, I don't know if we have any California people here, but it was developed in Newport Beach, California in 1983. And it's basically to allocate the limited resources to produce the greatest possible number of survivors. Each patient's rapid assessment or triage should be ideally completed in less than 30 seconds to a minute. So we start up at able to walk. So you can, a lot of times you can just call out, if you can hear the sound of my voice, follow me. And then walk them over to the green area, which stands for minor or walking wounded. For everyone else who didn't stand up and follow you, didn't follow your command, weren't able to walk, then you go down to check for spontaneous breathing. If there's no spontaneous breathing, you position the airway once with the jaw thrust or the head tilt, chin lift maneuver. And if there's still no spontaneous breathing, then you label them black. This is expectant where they're either deceased or mortally wounded and not expected to survive without significant resources. And this is probably the most ethically and emotionally challenging triage tag to put on. If I don't know if anyone here has ever done it, because you're saying they're going to die. Obviously, if resources change, you can consider resus or palliative care, but during a true disaster, CPR should not be performed. This patient should be labeled black. If there is spontaneous breathing after one repositioning of the airway, then you label them immediate or red. So they have a current life-threatening situation with good potential to survive with immediate intervention. So for this red tag, there are 4 ways you can get it. And the way I remember is the ABCD approach that we use in the emergency department. So this one is the airway, the spontaneous breathing after positioning airway. The next one after that you can also go into red is when you check the respiratory rate. If it's greater than 30, they also go to red. If it's less than 30, you go to C, circulation or perfusion. The initial triage developed in Newport Beach used the capillary refill greater than 2 seconds, but in 1996, they proved that the radial pulse had better accuracy, especially in cold environments. So if there's no radial pulse or the capillary refill is greater than 2 seconds, they're labeled red. If you do have either of those, you go to the final one, D, or mental status, and you check if they can obey commands. If they can't, then they're red. If they pass all 4 of those A, B, C, D, then they go to yellow, delayed. There's a couple other ways to remember this. Some people use the RPM, respirations, perfusion, mental status. The AWLS uses March, the massive hemorrhage, airway with C-spine, respiration, circulation, and hike versus helicopter. Since I use ABCD in the emergency department every day, I like to stick with that. But that's the START adult triage. So this is for the greater than 8-year-old. Here are just some examples of those 4 labels. So the green, walking wounded, can be like fractures without vascular compromise, abrasions without major hemorrhage. Delayed are non-ambulatory patients. They could have possible spinal injuries without a neurodeficit, and they could have had syncope, but now a normal mental status. Immediate or red is our critically ill but potentially salvageable patients. There's a lot of people go into here. That's when you hit any of those 4 ABCD markers. And then the deceased, as we discussed, is either pulseless and apneic or has a pulse but apneic despite one attempt at airway repositioning, because they have no reasonable chance of survival without many resources. So the jump start is used for children less than 8 years old, and it's pretty similar to the start. The green is the same. It's the minor walking wounded. Then you go to the spontaneous breathing, but the black label is where it changes. So you check for, you position the airway and check if there's spontaneous breathing. And if there isn't, you don't automatically label them black here. If there's no spontaneous breathing here, you check for a pulse. Then if there's no pulse and no breathing, that's when you label them black. Or if there is a pulse, you try 5 rescue breaths and there's still no breathing. That's when you label them black. So we try a little more on the kids. We give them a chance, a little more than the adults before labeling them as that black label. If they do get breathing after those rescue breaths, they go to the red immediate, or as with the adults, if they had spontaneous breathing after repositioning of the airway, they went to red immediate. After that, you go down to respiration rate, same thing, but instead of greater than 30, it's less than 15 or greater than 45 or regular, puts them in that immediate red category. The palpable pulse is the same thing. If there's no palpable pulse, it's red. And then the mental status, here they use an AVPU acronym. So that's alert, verbal, and appropriate pain. For example, withdrawals from pain versus inappropriate pain like posturing or unresponsive. So if they're unresponsive or inappropriate pain, you label them red. So again, those 4 things, the A, B, C, D gets them to red. If they pass all those, they get to the yellow delayed. So pretty similar, except for that, that checking for the pulse up before labeling them black. This is the medical emergency triage tag. Every organization has different ones, but they're basically the same. They include the vitals, sometimes a diagram of the physical exam, assessments, treatments, and the triage assignment with a tag, usually one for the patient and one for the chart, which keeps the triage and treatment information with the patient, which is important for the evacuation. Most triage tags have the start triage thing on them, so they can help you if you're kind of stressed in this scenario and can't remember all those steps we just talked about. So this one has that RPM there that helps with designating where they are. So why is lightning different? What changes the triage? Luckily, we just had a couple amazing lectures that went through all the pathophysiology and lightning injuries for me, so I can breeze through this. But lightning is different. It's not a DC or AC current. It's this unidirectional massive current flow over a short period of time that short circuits the body's electrical systems. Julie talked about how it causes simultaneous cardiac and respiratory arrest, and how the ROS precedes respiratory system recovery. And this is the big thing of why it changes, why we do this reverse triage. Since the ROS precedes the medullary respiratory center recovery, then a second cardiac arrest can occur if you don't support the ventilation. So that's why it's so critical to support the ventilation until ROSC occurs, and to do CPR as needed. All those other patients, if they don't have cardiac or respiratory arrest in lightning strikes, they have a very high chance of survival. These ones also have a high survival rate, 70 to 90%, but only if acted upon immediately. A lot of them do have some long-term morbidity, some neurosequelae, tympanic membrane ruptures, ocular injuries, but the survival is so much better than coronary artery disease, cardiac arrest. So this is why the reverse triage is so important. So the difference in the reverse triage, we have the START algorithm. There's only one big difference, and that's that there's no expectant black label here. When you position the airway and there's apnea, they become red. They become the most immediate, and you need to act on them first. The important thing is that you need to check the central pulse, as Julie said, because the vasospasm can cause loss of distal pulses, even with a central pulse. And these people can really look dead with those fixed and dilated pupils, the cold mottled extremities, but they're all due to the pathophysiology of lightning strikes, like Julie said. So it's really important to act on these people immediately. Obviously, obvious signs of death like decapitation or dependent postmortem lividity that would be different. And that's, I believe, why they stopped in that case we just heard about. They stopped after 90 minutes of CPR because that patient developed dependent lividity. So that's why they ended up calling it. So, and then transports. Julie again already went over our high risk indicators in lightning strike victims that helps you determine priority for transport. But the big thing is just extended CPR. Chest compressions during transport have been proven to be ineffective. So patients really should get the CPR treatment triaged on scene before transport. And as the scouts did, you can do this for 90 minutes, even longer, although AWS recommends to stop CPR if no recovery after 20 to 30 minutes. Transport, if there's major burns, you can consider a burn center for these patients. So these are my references for all of that. And then we're going to go to a scenario. So this is going to be interactive. So I'm going to need you guys to unmute and pay attention if you weren't. How many people do we still have here? We got a good amount? Cool. Okay, so basically, I think with the Zoom, the best thing to do is kind of all work together, chime in. We'll all be the incident command, and you'll all kind of, whoever wants to answer can answer instead of splitting up into breakout rooms or teams, because that might be a little difficult and lengthy. So for our scenario, you are a group of Forest Service Rangers in the Colorado forests. You're gathered for a multi-district training at the ranger station at about 8,000 feet along the Mount Evans Road. You're all EMTs, paramedics, and physicians. They've provided you with some trainings on wilderness medicine, including cold, heat, altitude, and lightning. As you break for lunch, a thunderstorm passes and a call comes in that some people were involved in a lightning strike event a half mile up the road. Dispatch asked for all available resources, and there's no need to leave anyone from your group at the station. Most of you have carpooled in vehicles, so you jump in to head up the road. You're planning to be in the field all afternoon, fortunately, so you all have lightweight backcountry medical kits. But you weren't planning to respond to an emergency. The Rangers from another district have a response vehicle with medical supplies, including ALS capabilities and technical rescue equipment if needed. The truck with these supplies is in your medical zone. At this time, you do not have patient transport capability, but you know that medical and transport resources have been activated by incident command. So you all make your way up to the scene, the scenic alpine roadside, and you arrive 3 minutes after receiving the call. The weather has passed, and there are other law enforcement rangers that are not part of your group who have stopped traffic. So you set up your ICS and you begin triage of your 7 patients. And our goals here are going to be to triage, treat, and transport in the appropriate order. And so that's our goals for this little scenario. So this is the scene. So you have a car on the roadside, you have patient 1 lying on the road. You have patient 2 under the car. Patient 3 is behind a barricade down the road. Patient 4 is inside the car. Patient 5 is on the roadside. Patient 6 is by the rock slabs, and patient 7 is by the speed limit sign. Just a reminder of our triage colors: the minor green, delayed yellow, immediate red, and black deceased, and some examples of them. Okay, so you're on scene. What do you do first?
I believe it was the customary yell of, "If you can hear me and walk, come to me."
Perfect. So patient 6 responds and says yes and starts walking to you. You notice some superficial trauma.
Set them next to the vehicle so they don't keep walking and walk off.
Okay.
Anybody else can? And then I believe the next phrase is, "If you can hear me and can't walk, wave a hand."
Okay. Did you want to put him in an area, patient 6, one of these like colored areas?
Oh, they're green.
Okay, cool. So you ask patients to wave their hand, and some of them do.
Okay, well, we start with, if they're waving a hand, they are conscious and they're reasonably responsive. We can almost go to the less responsive and figure out who is immediate versus deceased, which reverse triage, who appears deceased, who is not deceased yet.
Perfect. Okay. So you go up to your first patient who didn't wave at you. What do you want to do?
Check for spontaneous respirations.
Good. Yes, they have spontaneous respirations.
Good. Okay. How fast are the respirations?
The respirations are 20.
Okay, that's normal. Is he
Adequate depth.
bleeding out?
There is adequate depth of the breathing, and he is not bleeding out.
Is there a radial pulse?
Does he follow command?
I didn't hear the second person. You check a radial pulse, and you don't feel a radial pulse.
How about a central pulse?
Yes, there's a central pulse. Good job. Remember, for lightning strikes, we need to check the central pulse. Next.
What is the rate approximately?
What is the what?
Can we check? Do we know how it says bradycardic or tachycardic, or it's?
It's normal.
Oh, it's normal. That's good. All right. Let's put this person in delayed. Are they usually following commands? Seems like.
No, they are not following commands.
I would think that since he doesn't have a radial pulse, that means that he's hemodynamically compromised and therefore becomes an immediate concern.
Okay. So remember, for lightning strikes, the radial pulse can be due to the vasospasm. So you always need to check a central pulse, and that can be totally normal even with a lack of radial pulse. So his central pulse was great.
Correct, but he's not following command, so he'd be immediate regardless. I mean, he's a red category. Move on to the next patient. We on him. 30 seconds or less on each of these people.
Exactly. Good. Yes. 30 seconds or less. Good job. Can't follow commands, so you put patient 1 in red, immediate. Cool. Who wants to go up to patient 2?
Do they have any respirations?
Yes.
I guess what's the
Spontaneous
respiration
breathing,
rate?
20 per minute.
Central pulse.
Good central pulse.
Following commands.
Following commands.
Delayed.
Perfect. They can't walk, so they're going to delayed. Okay, you go up to patient 3 behind the barricade on the road.
Is he conscious?
Yes, they're conscious.
Is he breathing? Okay, I mean, yeah.
Spontaneous breathing, and it's good at 12 breaths per minute.
Okay, and his heart rate? Central heart rate.
The heart rate's about 80.
Is he responsive?
Yes.
Okay, he would go to delayed.
Perfect. Can't walk. So this patient 3 with 5 puncture wounds goes to delayed. Okay, patient 4.
Are we conscious?
No.
Are we breathing?
No.
Do we have a central pulse?
Don't forget to reposition the airway. If they're not breathing, you give one attempt to reposition the airway. If they're breathing, that would dictate where you would go from there. If they're not breathing, you would be black carded and you'd move on.
So you reposition the airway and there's still no respirations.
He's black, move on.
I'd
So
say that'd
remember,
be
this
a
is a
perfect answer, except for in a lightning scenario.
good job. Yeah. So lightning scenario changes are triage, reverse triage. So no
Mediate.
respirations. Cool. Patient 4, no respirations, weak pulse, back partial thickness burns, goes to immediate. Okay, next patient, patient 5 by the roadside.
Conscious.
He's moaning when with pain.
Okay, which means he's breathing. Do we have a central circulation?
Yes.
Do they follow commands?
No.
Immediate. Because he's altered mental status.
Exactly. Good job. Okay, and we already saw patient 6 and then patient 7 by the speed limit sign.
Conscious?
Yes, conscious.
Follow commands?
Following commands.
Oh, we're anything obvious injury wise? Any massive hemorrhage? Otherwise, we're green.
No massive hemorrhage, about 10% total body surface area, superficial burns, and a lot of pain.
Okay.
Where do you put him?
Green.
Green?
Or would this one be yellow since they're not able to move?
Yeah, so they're not able to walk, so they go to yellow. Remember, green we got with the walking wounded way at the beginning. Good job. Okay, so we placed them all in the place. What kind of treatments do we want to do?
We're gonna first
You
give
wanna
that
start-
person who's not breathing. We want to give CPR.
Yeah, patient 4 needs CPR. Cool, so you start CPR on patient 4 and he resumes breathing.
Yes.
Yeah.
Good job. Any other, at this point with these, any other treatments you want to do for them?
Well, now that we have a head count, we'll need transport for all of them.
Cool. Yeah. Okay, so you're still waiting for transport when patient 1's vitals improve and he's now able to ambulate and talk to you.
Put that
Cool.
person in green.
Cool. So patient 1 moves from red to green. Good job. Patient 2, our fractured ankle, his vitals deteriorate.
He goes to immediate.
Perfect.
Was that ankle fracture open or closed? I don't know if I missed that.
It was closed.
I'm a little worried about this
Um,
guy with blood running from his ears. I'm not gonna lie.
yeah, so patient 5 deteriorates, but still has a weak pulse and breathing.
Could have seen that coming.
Yeah. So he's already in red. So he stays there. And then patient 6, mental status deteriorates. So he's no longer able to
The
follow
vital
commands.
signs.
His
Just
vital
mental
signs are
status?
okay, just not able to follow commands.
He'd be immediate. He'd move him all the way down because he's not able to follow commands.
Sorry, say that again.
Since he's unable to follow commands, he would become immediate. Since he's
Perfect.
not.
Good job. Okay. And now transportation arrives. We have a BLS ground ambulance that arrives first with a 45-minute transport, and ALS air ambulance arrives second with a 12-minute transport. So what order do we want to treat and transport these patients? Who's going first?
Well, the people in immediate are not going with the BLS ambulance. So anyone in the delayed, I'd say, should go with them. And the minor at 1 over there should really just sit on the side of the road and hold tight. He's not important for the moment. We care about him, but
Okay, and who of the immediate would you send first in that ALS ambulance?
let's see, 6, 5, 2, and 4. So 6 is the superficial trauma. 5, I think this guy with blood running from his ears has got to go. I'm not gonna lie. Partial thickness, partial post no respirations, but he regained RASC. 5 or 4. 2 is the fractured ankle. I say 5 or 4. That's my vote.
Do we know like how much the vital signs have deteriorated? Just because like 4 has no respirations, but if 5 is like some.
Yes, 5 you don't have to give rescue breathing or CPR on. He's deteriorating, but his vitals are there.
I think we'd want to get 4 moving, right? I think I'd want to fly him.
Or transport gets here and 4 goes.
And they take one of the lesser critical with them, that doesn't need much management, and then use a bed space.
Yeah, definitely a good idea. So yeah, you said 4 first, and then you got 2 more ALS ground ambulances come. So a 45-minute transport. And I believe you guys all said 5 goes next there. Who next do you want on the ALS?
2. I agree.
2 got promoted to red.
Yeah, so 2 and 6. This one listed as 6 first, but yeah, 2 with the vitals deteriorating. Go either way. Okay, so we got all our immediate people gone. Who do you want to send on those BLS ambulances?
In theory, you could send them all at the same time. I mean, you could put 1 on the cot and 2 on the bench. I mean, that's not an issue. I mean, it just depends on the configuration of the ambulance.
So true.
I think this thigh puncture wound could be big. Like, is he bleeding significantly?
No, he's not.
Well, then I agree with the last comment. Let's just shove him on the back and get him out of there.
Yeah, well, we have enough ambulances. They can go on separate ones, but yeah, that's a good idea. Definitely, if you are limited, if they can handle it, to do that. Remember that 10% total body surface area is like a high risk. It classifies as high risk for those criteria. So they sent 7 first, and then 3, and then our 1 are walking wounded. And you got everyone home or to the hospital. Good job. Any questions on that?
So were you by yourself on this? Because, I mean, what if it took a really long time to come? I mean, you could put these people split between your car and that Subi over there and drive them kind of down the road, couldn't you?
That's true. This was not a real scenario, but that is if it was, you could try to use their car. The scenario said that you didn't have any of your own transportation capabilities. You had to wait
We just walked on them.
for
Okay.
patient transport.
Borrowing
A
a
good
ride
thought.
has happened before and it'll happen again.
And yeah, I think we covered some good things in there, remembering that reverse triage. So if you notice, no one was Black. We didn't label anyone as Black or expectant. Those people that needed CPR, they went to immediate. And good job with the walking wounded. And adjusting, remembering that people can change colors as their vital signs and mental status change. So always keeping an eye on that. They're not just stuck in whatever triage place you put them first. So yeah, good job with the scenario. This was, we don't have to watch this, but I found it on YouTube and I thought it was funny. But if Justin, if you want to cut me off at any point, you're welcome to.
All right, give the chief toys to keep him busy. Oh no.
I feel like they had a lot of fun doing this. But yeah, if anyone has any questions, comments.
So yeah, basically, kind of wanted us to just go through the thinking exercise of the actual patient triage and transport considerations. We could have gone through an entire MCI, but I've done that with one of the workshops with an WMS conference, and then with our recent DIM that I was the IC for, and it's pretty complicated to figure out on the Zoom platform. So I figured just as a good learning exercise to at least get the patient aspect of it and not just think about how to use the breakout rooms for an hour. So I thought this is the meat and potatoes of it. Any questions?
Your girl's name is Lisa? Anyway, their father was
All right. Well, to our presenters, thank you for taking the time to be so prepared. Thanks everybody for staying with us there for the entire full 2 hours. Any questions about lightning cases, physiology, how you'll kind of change what you do going forward? And I'll end recording in the meantime.